Next talk is going to be by Ling, Refinement in the Use of Silicone Oil in Retinal Detachment. I think that is something which is very, very important for all of us, the use of silicone oil. Yes.
Good morning, everyone. Thank you, Chairman, and thank you, Appao, for the kind invitations. So today I'm talking about this refinement in use of silicone oil in retinal detachment. Silicone oil was first used by Paul Anton Sibis in 1962 because of its transparency, chemical inerness, and high surface tensions. There are various of indications for use of silicone oil. Also, it depends on the surgeon experience. The most common one is treated with complex retinal detachment. Second, inferior retinal pathology, and some special case, those with severe tractional retinal detachment. And also, it depends on patient factor, those we intend to travel by air, non-compliant to the position, and only eye with poor family support. Basically, there are two types of silicone oil. The light or standard silicone oil only consists of polydimethyl siloxane molecule. And then we have a heavy silicone oil to tackle the inferior break. The silicone oil 1000 centistroke and 5000 centistroke have similar surface tension, but they are different in molecule weight. But which one is better? But in the study, there's no difference were observed in terms of anatomical and visual outcome, and there's no significant difference with respect to the complication rate in terms of rate of emulsification, IOP, and corneal abnormality over the 1 year. However, theoretically 5000 centistroke silicone oil are more resistant to emulsify over time. If the surgeon thinks you need to put a longer period of tamponade, you will consider 5000 centistroke. Heavy silicone oil was created to tackle the inferior break. The new formulation, Tensilon Extra, which added a 10% high molecule weight, make it more resistant to emulsify as compared to Tensilon 68. Meanwhile, it also maintains the low viscosity, moderate viscosity, which make it easy to inject and remove. You should worry about the heavy silicone oil in terms of emulsification and inflammation. However, it did better and higher primary success rate for inferior pathology. And also, you reduce and lower the rate of retinectomy intraoperatively, and also it provides better post-operative visual outcome, visual acuity for inferior break with PVR grade C. The newer formulation, Tensilon Extra, shows safe and effective for the use for retinal detachment, even though there's not much of comparative study. The complication of silicone oil, including the glaucoma, Benke, cataract, migration of silicone oil, but least common silicone oil-related visual acuity loss. If you use a heavy silicone oil, there might have a possible develop superior PVR. I would like to share two cases here. This is a very common scenario. Young patient, 25 years old, male with high myop, presented with inferior RD with inferior break. What should you do? What will you do? Ideally, this kind of patient will go for sclera buccal. However, this patient very concerned about the floaters and myopic shifts, so I did the vitrectomy with Tensilon Extra tamponade. 2 months post-operative, we go for removal of oil and follow up after 2 months. There's no complication noted, no cataract, and no emulsification noted. The visual acuity improved to 624 and no cataract. Another similar case, a young patient presented with left inferior RD with inferior break with a good visual acuity 6.9. I did a vitrectomy with normal standard silicone oil tamponade. After 4 months, we removed the cataract and also removed the silicone oil. Unfortunately, this patient come back 1 week with a counting finger vision. So the diagnosis of silicone oil-related vision loss was diagnosed. Silicone oil-related vision loss is typically occur at the time of silicone oil removal without any apparent explanation. They are frequently reported in cases with giant retina tear and macula sparing retina detachment. The etiology is unclear, but may related to the potassium saying the increased fibrogenic growth factor And also it might be due to phototoxicity and also reduce the antioxidant substance. This is my flow chart. If the silicone oil is indicated, it mainly depend on the location, the extent, and the PVR. For those retinal detachment with simple retinal detachment or compact retinal detachment with superior break, I will like to use the normal silicone oil 1000. Only for those very complex retinal detachment with PVR and also with inferior break, you might consider heavy silicone oil, or you also can do a retinectomy with a normal silicone oil or add in a sclera buckle with the gas as well. In conclusion, silicone oil has an essential role as a long-term tamponade agent in complex vitreoretinal pathology. The new formulation of Tensilon Extra show a promising result in terms of safety and efficacy. Although silicone oil is being challenged by other new substitutes like foldable capsular vitreous body, the hydrogen-based tamponade, and also medium-chain triglyceride, but I think it will still irreplaceable in the near future. With that, thank you.
Thank you very much for giving a very important talk on silicone oil. I have a question for you. The question is, this heavy silicone oil, Tensilon, especially extra, which you have used, how long you'll be able to keep it the longest? Because it's heavy, it's not like the other one.
Yeah. From the study, it can keep up to 6 months, but I tend to remove early within 3 months.
Okay. So have you seen any changes in the retina if you keep it that long, in like earlier?
Yeah, actually, even though reported less emulsify, but I observed they will start emulsify even after 2 months. But fortunately, because it's heavy, when you're doing removal of oil, I think it's easy to remove the silicone oil for the emulsifier oil, which is sink to the bottom.
Okay. Any question? Yes, please.
If I choose to use heavy silicone oil, I do not add on pucker.
Okay. Yes.
Usual silicone oil, 1000 centistore? Like,
Sorry again.
what's the gap between silicone oil injection and SOR in your RD patients? How much time gap you keep?
For normal silicone oil, so it will depend on the cases. Most of the time, I will remove within after 3 months, in between 3 to 6 months. And if the sometimes it depends on the cases, like extent of the PVR or development of the PVR. For young patients, I will keep for longer. And for those with the tractional detachment, those I will give for more than 6 months.
Okay. So do you start prophylactic anti-glaucoma medications, or only when they come up with raised IOP you start?
Oh, I will not start any prophylaxis unless the patient start develop glaucoma. This is one of the indication you might go in removal the oil in early.
Thank you. Very nice presentation.
Okay, thank you.
Thank you very much. Thank you.